Before I begin my introduction, I just want to remind everybody to turn off their smartphones. And if they're dumb phones, you could turn those off also. My name is Stephen Branfman. I was talking to somebody a few days ago, and we were talking about the program for NSECA, and she said, it looks like there's a really interesting talk on hand injuries. I said, yeah, it's my brother. She said, that's your brother? I said, Branfman? How many Branfmans do you know? So growing up, I was always interested in science, I was always interested in math, and I was interested in medicine. And in fact, I did book report after book report after book report on the history of medicine and the history of doctors and science and all kinds of stuff. And Gary was always interested in art. In fact, he apprenticed to a very well-known photographer and educational film strip maker when he was in high school. So, of course, I became an artist, and he became the doctor. Gary is a man of all seasons. He's an athlete. He is an artist in his own right. He is a huge supporter of the arts. And if anybody here is in need of hand surgery, he's been known very often to barter his services for your artwork. So don't hesitate. He's my brother. He's my little brother. I'm honored to introduce him to my community of clay workers, my brother Gary Branfman.
Thank you. It really is an honor and a pleasure to be here, and I assume that Stephen's introduction doesn't count towards my 30 minutes, right? Mine starts now. So without any further ado, I'm going to see if I could start the first slide, and we'll get right along to it. I'm going to try to get this done in 30 minutes, so we have a few minutes if people do have questions. If we run out of time, you certainly can find me or call me or seek me, and I'll be glad to answer them at any time. So basically, this is kind of cool that I can kind of see what's going on over there. And again, I'm really honored and pleased to be part of this conference. So I'm going to talk about ailments that tend to be common among artists, musicians, other people who use their hands frequently and commonly. One big thing I've found is when someone's employed by a company or a factory, they're forced to take breaks. When you're self-employed, you start doing something 6 in the morning. Next thing you know, it's 6 in the evening. You haven't taken a break because nobody told you to. And I think that's one of the reasons that it seems that these ailments are more common among artists, musicians, and the self-employed than among people who work in factories. If you think that I'm talking a little bit too slowly, let me know. I'll speed it up a little bit. So we're going to talk about the diagnosis, treatment, and prevention of these ailments, and that's presented by me. And as Stephen said, not many Branfman, so I'm pretty easy to track down. I think sometimes we take all our body parts for granted. I won't go into too much detail on other body parts, but our hands in particular. With the hand, the parent cares for an infant. The musician plays a sonata. The labor toils. And amazingly, the blind can see, and the deaf can hear. So that's kind of an introduction to how important our hands are and how you really need to take care of them and care for them because it's important that they last you a lifetime. Up. So this is me, just a little bit about my background. Is that I practice plastic surgery, and among plastic surgery, many specialists go on to do a lot of hand surgery, and a lot of the hand surgeons today are plastic surgeons. People tend to think that all we do is cosmetic surgery, which is about 10% of what plastic surgeons perform. They forget about cleft lips and palates and burn wounds and hand surgery and all the other aspects of our training. My background is I am a member of the American Board of Plastic Surgery, a member of the American Society of Hand Surgery, the Association of Hand Surgeons. Then in my spare time, I'm also a member of the Writers Guild, the Romance Writers of America, the Austin Film Society, the Anti-Defamation League Board, and the American Society of Magicians. Just, when I am... So I describe to all my patients that I do really believe that laughter is the best medicine oftentimes. And, we're talking about hands, little structures, that little bone there on the microscope. And you got to say that no one can argue that's a little humorous. So what is plastic surgery? It gets worse. So people do often say, why is it plastic? And many of you probably are aware of the word plastic actually comes from the Greek word plastikos, which describes the ability, as you do with clay, and to mold, to shape, to form. And that's where our title as plastic surgeons came from. It describes the ability to be shaped or molded. And we do more than just facelifts, although certainly they help pay the bills, breast augmentations. But today we're going to focus on the hand. The hand's unique abilities are carefully orchestrated by a precise amalgam of arteries, nerves, tendons, ligaments, bones, muscles, all within a specialized envelope made up of skin and fascia. The entire body has 206 bones. 25% of them are contained within the hands. Hand surgery wasn't a specialty before World War II, and when somebody had a severely injured hand, you would call into the operating room a neurosurgeon for the nerves, a vascular surgeon for the arteries, a plastic surgeon for the skin, orthopedic surgeon for the bones. It kind of got crowded in there working around a little hand. So after World War II, they decided as a group that there were so many hand injuries that people needed to be trained to take care of all these disciplines simultaneously. And that's when the specialty of hand surgery was introduced. The U.S. Army Surgeon General spoke with a friend of his who was a general surgeon who had a keen interest in hand. And again, from the World War II hand injuries is where the specialty of hand surgery evolved. Pretty much the father of modern hand surgery is Dr. Bunnell, and he constructed over 20,000 hands following World War II. And we all know all the history of art, how it concentrates on the hand with sculpture, with paintings, but we've come a long way since Rembrandt painted his paintings showing the tendons and the muscles. An all-encompassing discussion dealing with every aspect of the hand is certainly beyond the scope of this review. We won't discuss burn wounds, although everybody's aware of how hot a kiln can be, or the sharp knives used. The sprains, the strains, these are acute injuries which are beyond the scope of this conversation. But nonetheless, things to certainly be aware of, be careful of, and try to avoid. Today's dialogue will emphasize a category of chronic conditions referred to as overuse syndromes or repetitive stress injuries. We'll talk about the prevention, the diagnosis, the treatment, how to try to avoid surgery, and when necessary, what surgery is available to deal with these ailments. I don't understand why every potter doesn't end up with carpal tunnel and with tendonitis of the wrist. You know, this sort of thing looks like a controlled study in causing hand problems. As you masterfully manipulate mud on the wheel, or sculpt away the day, creating visual delights. Your hands, wrists, and arms absorb the stress of your skills and the turmoil of your talents. These repetitive motions of musculoskeletal units can result in repetitive stress injuries. And that's what we're going to focus on with today's talk. We're going to talk about the diagnosis, prevention, and treatment of these ailments as they relate to you, the potter and the ceramicist. So when forces are applied to your tissues, which can be nerves, tendons, ligaments, muscles, for prolonged periods of time, certainly minutes, hours, days, weeks, and then years, injuries develop. And if untreated, irreversible changes can occur in these structures, which can cause permanent impairment. So obviously the goal is to be aware of these problems early on and not just assume it's something that an Advil and some warm compresses are going to cure. So your goal after today's talk is know when your ailment needs more than just an Advil and some stretching. I mean, permanent is no way. Get it? Way? And it's way too high a price to pay. Okay, so this is my second break. This is how I kind of catch my breath a little bit. So laughter is the best medicine. This is gets a phone call in the middle of a doctor's visit. No, I'm sorry, but the doctor isn't in yet. Couldn't help. Couldn't resist, sorry. 3 common conditions can result from a combination of repetitive, strenuous, and chronic use of our hands, wrists, and elbows. Makes you just want to scream. These are tendinitis, also called tenosynovitis, neuropathy, and arthritis. These are conditions involving the tendons, the nerves, and the bones. And these are the most common problems we see in any workers who use their hands constantly, repetitively, aggressively for months, years at a time. So the first thing we'll discuss is tendinitis or tenosynovitis. Tendinitis is the most common repetitive use injury that we see in the hand. It can occur anywhere there are tendons, but certainly we're focusing on those of the upper extremity, specifically the hand and wrist. So the treatment for tendinitis, and it's pretty obvious when somebody begins to develop this, because certain motions of the hand, of the wrist, of the elbows, they just basically hurt. You know, it's everybody gets some tendinitis some point in their career, and this is where early on you use warm compresses, you rest, you stretch, you exercise, you take some Advil. So rest and immobilization is the first thing to do, which you won't do, so it's irrelevant. Cool packs, if the injury is acute. There's this big controversy to use cold packs or hot packs or warm packs. Really depends on what your grandmother told you to use. Everybody says that's where it comes from. But basically, cool packs are good for an acute injury. You have a sprain. Before you even examine it, ice it down, whether it's a potter's injury or sports injury. Local heat for the more chronic problem. Anti-inflammatory medications. Steroid injections, cortisone injections are oftentimes helpful, but I wouldn't recommend you try that at home. And surgery if all else fails. That's where I come in. So what are tendons? They connect muscles to bones, and as they glide, joints are flexed and extended. So that's what a tendon does, connects a muscle to a bone, just like the string on a string puppet. You pull this tendon, and it makes a part move. Repetitive movements can cause persistent friction. These tendons are constantly rubbing and gliding, and that's what they're supposed to do. But if you don't take breaks, don't rest, you overuse them, this friction can certainly cause an effect of interrupting the normal gliding mechanism. So 2 specific tendon disorders are endemic to ceramicists. They're called trigger finger, and it's funny, just through the next couple of days, how many people I spoke with here either have trigger finger or have had it operated on already. The second one is called de Quervain's tenosynovitis. So if you look at the anatomy of what a trigger finger is, there's a series of fibrous pulleys through which the tendons glide. It's kind of like the line on a fishing pole where the line goes through and you have these little pulleys. So if you have a big old knot in the fishing line, it's going to get stuck on these pulleys. That's what trigger finger is. There's a nodule develops on the tendon, and it gets stuck when it tries to get through the pulley. So there's the tendon going underneath the pulleys. And then if you have a swelling area of the tendon from overuse, it can't quite fit through the pulley, so it gets stuck. So if your finger is flexed when it gets stuck, that's how it is. If it's straight and it gets stuck, so that's why people with trigger finger can present with a finger they can't bend or a finger they can't straighten. So if that's the locked finger, that's what a tendon looks like once it's been freed up and the tunnel has been made larger. To correct the trigger finger surgically, you basically take the area where the tunnel is too tight and you make that tunnel larger. It's just a physical operation. It takes about 10 minutes. It can be done under local anesthesia. The second of the 2 most common tendon conditions is called de Quervain's disease. And that's on the dorsal, which means the back, like a dorsal fin. Radial means the side that the thumb is on. There are 2 tendons which go through a tight tunnel. If these tendons become swollen, they don't get stuck because it's a very large tunnel and they're large tendons. It just hurts. So that's the area. Those are the inflamed tendons. That's the tight tunnel. And painful inflammation radiates from the thumb to the forearm. And it's one of these conditions that's not that common, so people walk into a walk-in clinic or their family doc, and they'll have no clue what it is, and that's the delay in diagnosis is why some of these patients need surgery. If this is treated early, it's pretty simple. Warm compresses, a splint, second time you do a steroid injection, and most of these can be treated non-surgically if they're caught early enough. So there's a specific test that you can do for de Quervain's disease. You put the thumb inside your closed fist, like so. You bend the wrist down away from the thumb. And then the telltale sign of a positive test is when you do this thing, you have the sudden desire to yell. That's what a positive test for de Quervain's disease is. So this is how we release.
This is what I grew up with.
So this is an operation taken during surgery, where you see the red portion is inflamed. That's the actual tunnel. The white portion you see is the actual tendon within the tunnel. You take that tunnel and you open the portion of it where it's offending the tendon. And that's what it looks like after the tunnel has been released. And then the tendons glide easily. Again, this is not something you should try at home. So this snake charmer has had the same snake his whole life, and it's been doing great. All of a sudden, it just won't work anymore. So he goes to this medical clinic, and it turns out to be a Viagra clinic, and he's told by the doctor, your snake has a case of erectile dysfunction. Okay, moving right along. So that's tendinitis. There are dozens of other types of tendinitis, but those are the two most common. The second topic we'll talk about are neuropathy, which is basically nerve entrapment syndromes, which means as opposed to a tendon being stuck, often in a tight tunnel, a nerve is being stuck in a tight tunnel. We'll talk about arthritis. We'll do the last portion of this discussion today. But neuropathies can be broken down into several types. Nerve compression syndromes is just what it says. The nerves are being compressed. When you compress a nerve, everybody knows the old, you hit your funny bone. Well, that's a nerve is being hit. It can result in a variety of symptoms which together make a syndrome: pain, numbness, weakness. And if untreated, you can really develop permanent nerve damage. So again, the idea is to have this diagnosed before it becomes an irreversible condition. And there's some confusion. There's this carpal tunnel syndrome. There's also the carpool tunnel syndrome, where you have a tunnel and you can't quite fit through it. And it says it's only for carpools, and if you try to get through with too many people, then you develop carpool tunnel syndrome. That's not to be confused with carpal tunnel syndrome. Now we'll talk about carpal tunnel syndrome. It's the most common of the nerve compression syndromes. The term carpal is from the Latin word which simply means wrist. If we throw in a little Latin, it makes us seem a lot smarter than we are. If we called it, you got wrist tunnel syndrome, it's not that big a deal. But carpal tunnel syndrome basically means wrist. You have the carpal bones, the carpal ligaments, and the carpal tunnel. Is this tunnel in the wrist where 9 tendons pass through that tunnel and 1 nerve, the median nerve. The nerve within the tunnel, the median nerve, is responsible specifically for the sensation to your thumb, your index, your middle finger, and half of the ring finger. So if somebody comes in and says, my pinky is numb, you know it's not carpal tunnel syndrome. It's really a pretty easily diagnosed problem without going through x-rays and nerve studies and this big old workup. They were able to diagnose carpal tunnel syndrome way before they invented MRIs and CTs and nerve conduction studies. So the thumb, index, middle finger, and 1/2 of the ring finger. And it's really pretty common. A patient comes in and says, it's weird, this side of my finger is numb and this side is not. I mean, that's diagnostic for carpal tunnel syndrome. It also, 3 of the muscles in the thenar eminence, which is this area of your thumb, it also is responsible for the motion of those. So if you have carpal tunnel syndrome, you get weakness in those muscles and numbness in those fingers. The roof of the tunnel is this firm, fibrous ligament. What a ligament is, or fascia is, this white tissue, it's a tissue when you're skinning a brisket and it's really thin white tissue that you can barely even tear. That's what this stuff is made out of. So any condition causing swelling in this tunnel can result in pain, numbness, a tingling sensation, and weakness. Most commonly, from overuse, the tendons get swollen, the nerve is soft and mushy, so it doesn't injure the tendons, it squeezes the nerve. It just gets too much stuff inside that tunnel. So the number one way to avoid it is avoiding keeping your wrist flexed for any long period of time. It doesn't do carpal tunnel syndrome. It'll cause other problems, but the idea is to hyperextend, to flex, to go through all the motions when you're stretching your hand. We won't have time really to go through exercises today, but you can get online and just Google exercise to prevent carpal tunnel syndrome. They're all over the internet. So if conservative management fails, then you have to resort to surgery. That's what an irreversible thenar atrophy looks like in somebody who has neglected their carpal tunnel syndrome for too long. And that's permanent. That doesn't get better after you do an operation. So that's what you do not want to do for any length of time. That's, when you're sitting, you got to think, what position are your hands in? That's okay. So to help prevent carpal tunnel syndrome, stretch your wrists. I mean, that's just take breaks every hour. It doesn't matter what you do, and it takes 15 seconds. Just move them around. There's lots of yoga exercises or other physical therapy, occupational therapy, and that's the idea. Is just don't sit like this, don't fall asleep like this, don't drive like this. They talk about wrist splints, which help, but the purpose of a wrist splint is simply to remind you not to bend your wrist. Stretch them, move them. Or have someone else stretch them, whatever you want to do. So this is a splint which is custom made by our therapists versus ones you could buy over the counter. We have a saying in hand surgery, a splint that fits everybody fits nobody. If you really have carpal tunnel and you want to treat it, have a hand therapist, physical therapist, make you a splint that fits your hand. Or just, do a little stretching, do a little yoga. I mean, everybody, first thing in the morning, this is, I think, what everybody should do. Okay? And, that's the hyperextension exercise. I do that every morning. The second most common nerve entrapment is called cubital tunnel syndrome, which is a nerve which is located on the elbow, and that's the nerve that we refer to as the funny bone. When you hit that nerve, you get that electric tingling into your fingers. So if you look at the anatomy, which we've discussed, early symptoms of cubital tunnel syndrome include those things not typically involved in carpal tunnel syndrome. You have numbness of those other fingers, the pinky and the other half of the ring finger. And weakness of the fingers. So that's the ulnar nerve, which is what causes cubital tunnel syndrome. You can see where it goes to. That's the median nerve for carpal tunnel syndrome. So it becomes pretty easy to understand why certain syndromes cause certain symptoms. The confusing thing is that what you see in a textbook for the nerve anatomy is correct 85% of the time. 15% of the time, there's an anomalous nerve or connection of nerves. They go the wrong place. So it's a problem among doctors trying to diagnose these things. They have to be aware that what the textbook tells you isn't correct all the time. There's a lot of anomalies. The most anomalous nerve in the body is the carpal tunnel nerve. Again, 15% of the time, it's not where it's supposed to be. So as opposed to the thenar atrophy you get from carpal tunnel syndrome, from cubital tunnel syndrome, you get these two fingers start to claw. And then the muscle weakness is on the back of your hand. And that's a patient of mine who came in kind of a little too late to have anything done about this. So with carpal tunnel syndrome, avoidance of wrist flexion. With cubital tunnel syndrome, avoidance of elbow flexion. Again, doesn't mean you can't do that. It means you can't stay in that position, fall asleep like that for 8 hours or 6 hours or 4 hours or however long it is you sleep. So if you look at the operation for cubital tunnel syndrome, this guy's throwing a little teapot. So that's an incision on the elbow. You're looking at the nerve to the right and the tunnel to the left. So that's the point at which the nerve is entrapped. So you basically take that tunnel, you make it larger. Take a scissor, you snip it, and then you see the nerve. And that's all there is to it. It's really pretty straightforward. There are so many nerve entrapment symptoms of the upper extremity, and again, since we have 9 minutes left, I'm going to just skip through these slides and not go over them. But again, that is one of the problems with diagnosis is most doctors know about cubital tunnel, carpal tunnel, they trigger finger, but when somebody comes in with a different nerve problem, it's really a matter of making sure that patient is referred to someone who could diagnose it and treat it early in its course. Pronator syndrome is one of them where you get an aching in the forearm. Interosseous nerve syndrome, I love this because the diagnostic sign is you can't make the OK sign. You can't do it. So when somebody comes into the office and they say I have this aching pain in my arm, you say go like this. If they can do that, it's fine. If they can't, it's diagnostic of this condition. So if they say I'm OK, they don't have it. You could also have that ulnar nerve at the elbow can also have an entrapment at the wrist. You get the same sensory findings, but you don't have any motor involvement because the motor branches come off before it gets to the wrist. It's called Guillaume's canal, which is to the left side of your wrist, right over there. The only nerve syndrome which I will go into detail on, not because it's common or because people see it all the time, but because it's such a cool operation. It's on the front of the elbow. So that's a drawing of what it looks like. That's where the nerve goes in a tunnel. And it's not common to have an entrapment there. This is more common in athletes, in powerlifters and bodybuilders. But people who do heavy pottery lifting, and I've seen this. This can happen. Again, not very common. 3 nerves go to your hand. That's it, median, ulnar, and radial. So any condition in the hand that's a nerve-related problem, you should be able to diagnose by knowing the anatomy of these nerves. So if you move the skin out of the way, you have something called fascia, again, like on our briskets. You move the fascia out of the way, and there's a muscle. You move that muscle out of the way, and there's a nerve. And that's the operation. You move everything out of the way, and you free up the tissue that's constricting the nerve. But then do a little more. It has these little branches coming off it that go to these finer muscles. You got to dissect and find those branches. And again, I see this operation probably 3 times a year, but I really like when I see it. It's so much fun to do this. And unfortunately, since it's not a common problem, oftentimes, by the time I see it, that conservative management is not an option. So we discussed tendinitis. We discussed neuropathies, The last topic, which I'll go over in about 30 seconds due to the time constraints, is arthritis. Everybody gets arthritis. Arthritis basically means that you have wear and tear on your bones and on your joints. We're not talking about rheumatoid arthritis or scleroderma or all these other syndromes. We're talking about wear and tear on our bones. A general term referring to any inflammation of a joint is called arthritis. Joints are the hinges between our bones that either permit or impede motion. So this guy walks in the doctor's office and he says, Doc, it hurts when I push here, when I push here, when I push here. Doctor says, well, Fred, that's what you expect with a broken finger. So you can talk about a joint inside a finger. So this is a joint that permits motion. And this is a joint that impedes motion. Okay, so you need to know the difference between these two joints. Just saying. So in osteoarthritis, the findings you get is this protective cartilage wears out, the bones begin to rub against the bones, and then you get these symptoms, this crunchy sound, this pain, stiffness, swelling, inflammation, cysts. The most common arthritis we see in artists and ceramicists and potters is at the base of the thumb. So what happens is there's a shock absorber, and that's a normal X-ray. And you could see where the thumb joint hits that little bone. And this is what happens in arthritis. There's no shock absorber. You don't need to be a doctor to understand and visualize how the bones are rubbing against the bones and the bones are wearing out. Since I have 1 minute left, hand exercise and stretching positions, you can find this online, or you could contact me. I'll be glad to send you these. But this is just a variety of some of the many hand stretching exercises to do. Again, you don't need to learn to do this. Just look at your hand. Go through every motion that your hands do, one finger at a time, your wrists, your elbows, flex it, extend it. And you don't need to do this with any resistance. Just do this. You know, you certainly get a rubber ball to squeeze helps. You get those hand grips that they sell at Academy, you know, to go through the exercises. But the most important thing is not to keep your hand in any specific one position for hours and hours on end. That's a kind of a clever thing I've seen. Where you take a rubber band and you wrap it around the hand, then you kind of get some resistance with your thumb. It's kind of like doing a Pilates with your hand. Okay? It's also good if you do like hand puppets. Kind of gets you in that mode. So just my final pictures. These are for women. It's amazing with the internet these days how much information you can get. So they actually were all living in Eastern Europe. They found me online. They all came and visited me. This is when they greeted me, and when they left my office, this is what they looked like. It's pretty amazing. And I want you to know that my talk lasted 30 minutes and 18 seconds, if that's not well timed.